So in the room today, we have Dan Crawford, CEO and founder of Axial 3D, Kathy Coomber, Operations Manager, Axial 3D, and Dr. Tim Brown, Consultant Transplant Surgeon, Belfast City Hospital. So please do get involved, ask questions throughout the webinar, and we'll get through as many as possible during the Q&A at the end. And Dan is going to start us off.
Thanks, Nigel. And just to reiterate on Nigel's point, my name is Dan Crawford, and I'm the founder of Axial 3D. And I'm super excited to tell you how we're going to be changing the face of medicine. And the way we're going to be doing this is by making 3D printing in hospitals completely routine, by transforming everything traditional in medicine, like CT and MRIs, into 3D physical objects with the aid of artificial intelligence. And these 3D prints provide huge benefits over traditional methods, making surgery faster for surgeons, cheaper for hospitals, but more importantly, it's actually safer for patients. So what this practically means is the process of taking medical images and delineating the anatomical structures that we need out of these, and then reconstructing these into one-to-one scale physical models of what's in a patient's body, like you see here. And when you boil Axial 3D down as a company into one concept, it's about making patient data real. So we live in a 3D world. Our bodies are made up of thousands of complex three-dimensional structures. So your surgeon's at a huge disadvantage when he or she goes to treat you, because everything traditional medicine is done on two-dimensional screens. So I've been 3D printing in the medical world for around 5 years now, and each and every case that I've worked on has had a huge effect on a patient's outcome, whether it be to improve diagnosis, improve an outcome, or enabling a surgeon to learn something completely new about a patient that he or she hasn't seen from traditional methods. For one of those examples, I wanted to pass you over to Dr. Tim Brown, a transplant surgeon based in the City Hospital here in Belfast.
Hi everyone, thanks for joining us today. As Dan says, my name is Tim Brown. I have an interest in complex kidney transplantation in Belfast City Hospital. What I thought we'd do today is, and I'd just like to, as the slide shows, issue a bit of a warning, because there's going to be some fairly graphic surgical anatomical images shown in the next few slides. So I thought I'd kick off a little bit by giving you a little bit of a background about what kidney failure actually means. As our kidneys function normally, they're able to get rid of toxins, get rid of water, get rid of waste products, but also they have a hormone production side of things as well. And as kidneys, if they do develop a disease process, if they do start to fail, we start to find that the toxins that they normally get rid of accumulate in the body, and that makes us unwell. Some of the symptoms of this, basically, it's the whole body feels awful. You develop tiredness, itching, you feel sick all the time, and as well as that, because of the hormones that kidneys make, people develop anemia and bone disease. But perhaps the most life-threatening aspect of renal failure is the lifetime risk of cardiovascular disease. And the vast majority of patients with kidney failure end up dying of stroke or heart attack. So it is a multi-system problem. So when the kidneys fail, we're actually in the fortunate position that we're now able to produce what we call renal replacement therapy. And that comes in 3 flavors. We can have dialysis, and that can be either peritoneal dialysis, which this slide demonstrates, where we wash some fluid into the abdominal cavity. The toxins very slowly filter across the peritoneal membrane, and then later on in the day, the patient empties this out. So a very slow and soft and good method of dialysis if patients are still active, and this is a good method of dialysis when people are just entering renal failure. It doesn't last forever, and whenever peritoneal dialysis fails, we have to move on to hemodialysis, which is a lot more invasive and time-consuming. Patients typically need to come to hospital 3 or 4 times a week for 4-hourly dialysis sessions, and they can. One of the big problems with this is hemodialysis access, where people have a line in their neck or a fistula created in their arm, where blood is taken out of one vein, sent to the machine. The toxins are washed out by the dialysis machine, and then reproduced back to the body. It's very time consuming. People generally feel exhausted afterwards, and there are a lot of side effects around the vascular access. in this. However, in Belfast, what we've developed is a model where we, across the world, people talk about aiming for renal replacement therapy to start with a fistula first. In Belfast, we're very, very keen to start with a transplant first. And what we've aimed to do in Belfast is to transplant people in what we call a preemptive fashion. So they get a kidney transplant before they've ever seen dialysis. This has benefits for both access problems from the dialysis perspective, but it also leads to a longer and better quality of life for the patient rather than starting on dialysis. So what I'd like to do is take you through a real life case. This is one of my patients. This is, shall we say, let's call her Pauline, who's a 22-year-old lady who has kidney failure. She's had a previous transplant before, which has now failed, unfortunately, after 4 years. She's previously had peritoneal dialysis, but this has now failed. She's moved on to hemodialysis, but unfortunately she's running out of options because the veins that we use to access her for hemodialysis have all scarred up, and she's now running out of time. She has what's called a very high sensitization rate, so she's going to be very difficult to find a kidney for, and I would suggest that she has less than 6 months to survive on dialysis. So fortunately for Pauline, her father, William, has come forward as a donor. He's a 45-year-old gentleman. He's well other than some epilepsy in his past medical history, but is what we call a tissue type match for her, but unfortunately they're incompatible in terms of blood group. So he has been accepted for the Living Donor Assessment Program, where we look at him in great detail. We look at his kidney function. We look and see if the left and the right kidneys are functioning appropriately. We take pictures and images of the kidneys and find out what the vascular supply to each of the kidneys are. We also find out if he is in good enough health to be able to tolerate living with one kidney for the rest of his life. So when I say they're blood group incompatible, what do I mean by this? So William's blood group is B and Pauline's blood group is A. If we were to give William's kidney to Pauline, immediately that Pauline's blood comes into contact with that kidney, because she has already got antibodies preformed against blood group B, the antibodies will stick onto that kidney and cause the kidney to die as soon as I take the clamps off and introduce Pauline's blood into her dad's kidney without treatment. And that's an important point which I'll come back to later. As well as during the workup, which we take very seriously because our donors are our heroes. Without our donors, we don't have a transplant program, so we look after them extremely carefully. Part of the workup, we looked in detail at his kidneys, and this is an MRI scan that you can see. On the screen, if you're looking at the screen, on the left side is his right kidney, and on the right side of the screen is his left kidney. It's just one of the conventions of radiological imaging. On the left kidney, you can see a large hole at the back of the kidney, and that in actual fact is a cyst within the renal substance itself, which clearly causes us concerns. And when we look at that cyst in more detail through a number of images, we can tell that there's a potential that this is actually a cancer within the kidney itself. So what are our options for Pauline and William? So do we put them into what's called the UK Paired Exchange Programme? Do we just list Pauline for a deceased donor, or do we continue with an incompatible transplant using this deceased kidney? So I'd like to explain to you, first of all, what the Paired Exchange Programme entails. Because William is blood group B and Pauline is blood group A, as I've explained, the two can't mix together. But, for example, these two are in Belfast, and for example, if a pair of patients are in Oxford or London or Edinburgh or anywhere else in the UK, and they're registered in the Paired Exchange Programme and happen to have a reversed blood group, so we've got a blood group A donor going to a blood group B recipient, instead of them going directly, we can take the donor from Edinburgh and send the kidney to Belfast, and we can take the Belfast donor and send that to Edinburgh. So instead of having a direct transplant, what we're doing is that swapping the kidney, so the patients are both receiving a kidney, but a blood group compatible kidney, and that's so much more successful for them in the long run than doing what's called an incompatible transplant. So the other option, do we put Pauline on the deceased donor list? Pauline is what's called a highly sensitized patient, and using algorithms from NHS Blood and Transplant, we can estimate the amount of time that she'll wait on the cadaveric transplant waiting list. And we estimate that she will be waiting for about 7 years before a compatible kidney comes available for her. Of course, she can be hugely lucky and get one on the night that she is listed, but this is very, very rare. And given the state of Pauline's incompatibility, or highly sensitized state, she'll wait for about 7 years. And given her vascular access problems, she's very unlikely to wait that long, so therefore she's most likely to die on the waiting list, which 3 people do every day in the UK currently. So just to illustrate that, she has, for every blood group B donor that comes available in the UK for Pauline, only 1 in 200 of these donors will be actually suitable for her because she's so highly sensitized. So you can see that this really isn't a very good option, although of course we will list her on the cadaveric waiting list in case she does win that lottery of getting a perfectly matched kidney just out of the blue. So what do we do with an incompatible transplant? It's really the only option that we have available because the paired exchange scheme is unlikely to yield a kidney that will be suitable for her. And as well as that, transplant surgeons across the UK are very unlikely to be willing to take a kidney that has a potential tumour in it. So we're really only left with the only option of performing an incompatible kidney transplant on Pauline from her father, William, who has very kindly come forward, albeit with a diseased kidney. So what are our options? We're going to have to sort this kidney tumour out, whether William donates or not. So what can we do? What are our potential options? Do we take his kidney out, transplant it into Pauline, and then keep an eye on this to make sure that it doesn't develop into anything more nasty in the longer term? Probably not a good option. Do we take the kidney out, put the kidney in a bucket of ice on the backbench, and then take a microwave probe or a cryotherapy probe, put it into the middle of the tumour, and then burn the tumour to get rid of it before then transplanting it into Pauline? Again, a very good option, but the problem with that technique is that we do not get histopathology from the pathologist to tell us and inform us how this kidney should be followed up in the long term. Do we take the kidney out, transplant it, and then take a radiofrequency probe and pass it percutaneously through the skin into the transplant and burn the kidney tumour while it's transplanted into Pauline? Again, probably not a good option given that we've got the ability to deal with the tumour on the backbench. And this is the option that we've chosen. What we're going to do is we're going to take the kidney out, remove the kidney tumour on the backbench, then repair the kidney, and then transplant that back into Pauline. That's called an ex vivo partial nephrectomy and allotransplant. So if I can remind you about the image that we've seen earlier, you can see that the tumour is buried deep within the kidney. So whenever I remove the kidney, I'm not going to be able to see the tumour in order to guide me whenever I need to resect it. And that's when we need to talk about planning, and we brought Axial 3D in. And I'll pass over now to Kathy, who's going to talk to you about the bespoke planning that we were able to get from Axial 3D. And I have to say, before I hand over, I'm indebted, and my patients are indebted to their help for their mission in this case. Thanks very much to them, Kathy.
Thanks, Tim. Yeah, just as a reminder, I'm Kathy Coomber, and I'm the operations manager in Axial 3D. So Tim and the team at Belfast Trust came to us with this case and started up a conversation about how we can provide a tailored, personalised option for his patient. And what I'm going to do now is bring you through the process of how we created the 3D replica kidney for Tim. So we took the 300 images, the CT images, which Tim provided for us. And what we did was delineate the anatomy which Tim required, which was the kidney, the tumour, and the surrounding vessels. And what you can see here are the results of the segmentation. We then verified this with the clinicians and then in our own team as well. And this is quite a labour-intensive process, with a lot of the work being carried out being manual, and it took around 3 hours to produce this 3D printable file. So after we had the file ready, we were able to put it into the printer, which took around 15 hours to print. There's a number of then processes in order to produce the model. So it has to have a UV cure in order to remove any excess material from the model. And then with Tim's guidance, he provided us which colours he wanted us to contrast so that he could accurately see where the tumour was in the 3D space.
Thanks, Kathy. So that was just one of the cases that we've done. So I wanted to kind of give you a flavour of what other cases Axial 3D are currently working on. So another patient I wanted to introduce you to is Jonah. So Jonah's case is something that we see nearly on a daily basis now at Axial 3D. So it's a case that's hard to diagnose, hard to plan, and one that needs to be right first time. So Jonah's a 14-year-old boy who's suffered from scoliosis all of his life. He's gone through multiple surgeries, one of which was last year when he was getting metal rods taken out of his spine. And one of the surgeons, Mr. O'Brien, approached us with 900 CT images. With these 900 CT images, Mr. O'Brien and his team had to make a conceptual understanding in his head of where Jonah's anatomy sat and the metal implementation in the spine, and make a plan with him and his neurosurgeons on how he was going to treat Jonah. So with these 900 images, Mr. O'Brien came to us and basically told us he was going in blind. He couldn't get a full conceptual understanding of where the anatomy lay. So with these images and using our newly developed machine learning algorithms, we've been able to segment this model, which would have taken us around 3 or 4 hours, and reduced it to a matter of minutes, and making it into one single physical model of Jonah's spine. So using this, his surgeon was able to see the exact extent of the damage of the pelvis and his spinal cord. And not only this, Mr. O'Brien was actually able to diagnose 3 additional fractures on Jonah's ribcage that occurred as a result of the metal work. This allowed him to prepare all the equipment that he needed well in advance of stepping foot into the operating theatre, which in the NHS or any healthcare system, it provides huge cost savings. For the NHS, for example, every minute in surgical theatre costs around £60. So not only that, because he was able to diagnose the other rib fractures, he was able to fix every pathology at once, meaning that Jonah was able to spend less time in theatre without the need of an additional surgeries. And this is literally one of the hundreds of patient cases that are being helped by 3D printing every week around the world. So for those of you on the call who don't know, 3D printing has been around since around 1984. And in medicine, its presence has been around since the early 90s. And with the recent desktop revolution, prices of 3D printers have gone down by as much as 99%. So it opens up to additional markets. So we kind of stepped back as a company and said, why is this not routine? And for us taking a step back, we could see 3 main bottlenecks in the technology not being adopted by every hospital across the world. So getting access to the raw images and an accurate prescription of what surgeons actually needed from a 3D print was a little disjointed and clumsy. So to get around that, we've created a novel web application to take in data. But the main issue is taking 2-dimensional scans and converting those into 3D models. So that was the main process, which was the bottleneck in this technology being adopted. And this is a process of segmentation, it's commonly referred to. And this process, put simply, is the way in which you take a medical imaging data set and annotate the anatomy that you want within those images to be printed. It requires knowledge of medical physics, anatomy, engineering, and a general understanding of the principles of 3D printing to make sure that the anatomy that's being segmented can be 3D printed for a specific technology. And with each data set being made up of hundreds of images, it takes hours for each of these models to be made. And if you look at the amount of complex surgeries actually being treated every year around the world, it's completely unfeasible for 3D printing to be commonplace in medicine if we continue down this road. So we're working on developing a comprehensive pipeline now for implementing machine learning into the segmentation process to completely eliminate it. We're already on track to collecting the world's largest repository of training data for 3D printing in medicine. And with the team, we've already created around 50,000 images to actually use as a base training algorithm for segmentation, and have access to over 3 million now with data collaborations with the Innovate UK Biobank. So we spent nearly a year working on a patent-pending software to completely automate this process of segmentation by using machine learning. And with our convolutional neural networks, we're already seeing the time taken to actually create 3D printable files from scans drop from hours to minutes. And once these develop further, we can completely automate this and make it possible for 3D printing to be done entirely in a hospital by every hospital around the world, which is ultimately what we want. We want 3D printing to be as accessible as X-rays in hospitals. By using artificial intelligence, we can make 3D printing accessible to every hospital across the globe. So we already know that having regular access to 3D printing can save hundreds of hours of surgical time for hospitals, and in some cases it can save lives. So it's the next logical step for radiology to get into. And now I'm going to pass you back to Tim, and he can give you a little bit more detail on the 3D print that was provided by Axial 3D for this specific kidney case.
Thanks, Dan. So back to our case, Pauline and William. You can see here, this is the 3D model that they created for me, which was extremely helpful in planning the operation and also conceptualizing it in our own heads prior to getting into theatre. That really was a very invaluable technique. So you can see that the kidney's been made out of a clear plastic, which allows me to visualize where the tumour is, and the tumour in this case is coloured in black, the renal artery in red, the renal vein in blue, and the ureter and the collecting system of the renal pelvis in yellow. You may be able to make out in the background there's a green shape, and that is a normal cyst. So the normal cyst we don't need to do anything about. The black is a Bosniak 2B, 2F or 3 cyst, which has a 25% chance of actually being a renal cell carcinoma. So if you're going to do a transplant, first take a kidney, and here is the kidney in real life. The little tube on the left of the screen is the renal artery. The little tube that I'm holding up between the two forceps is the renal vein, and the tube coming out of the bottom of the kidney is the ureter. You can see that the kidney is a nice grey colour, and that means that the blood has been successfully flushed out, and this kidney's been prepared and is ready for transplant, apart from the fact that there is a tumour that needs dealt with. So this is the back side of the tumour of the kidney, and you can see that we've used the 3D model on the back bench, and you'll see a picture of that in a second, to guide where we think we need to make our cut to excise this tumour, and the little purple spots are actually just pen marks which are guiding where I'm going to make my cut. So off we go, choppy. And here we go, the tumour is on its way to being excised. You can see that the parenchyma, the kidney function, the kidney structure itself is a nice tanned colour without the blood in it, and we're taking that out in contrast to the blue structure, which is the tumour. And you can see that I've got a nice margin of normal kidney tissue around the tumour, which is exactly what I want. And here we go. This is the model that we've been kindly given by Axial 3D, and you can see it sitting beside the kidney in real life on the back bench, with the tumour completely excised. In a really a mirror image of what the 3D model has shown us. what do we need to do next? We need to have a look and see if there are any areas within the kidney itself that need to be repaired. And here's a hole in the collecting system that would leak urine if we didn't fix it. So put some stitches, small stitches in there to close off the collecting system. And then we're going to do what's called a renorrhaphy. So make the kidney shape look good again. And I'm going to use a cardiac surgical technique using Teflon buttress sutures to hold the renal parenchyma or the renal substance back together again. And we're going to squeeze it closed so that we get hemostasis, so that the space where the tumour came out of wouldn't bleed anymore. And you can see here the finished article. So so one of the main reasons that we've gone for this technique as opposed to frying the tumour with cryo or radiofrequency ablation is that we can do this. We can send this tumour, this is the tumour that's been chopped in two, we can send this off to the histopathologist. He can do what's called a frozen section and look at the tumour under the microscope to tell us if we've got safe and clear margins. That means that we can then get on and do the kidney transplant. So this is the kidney transplant itself, and you can see that it's grey. I've taken the clamps off, and you can see the kidney going nice and pink. And this is the blood supply going back into the kidney and bringing it back to life. And you can see the renal artery pulsing away there. And I'm delighted with this image because that means this kidney is going to start making urine and will be good for Pauline for the next 40 years with luck. Nice image. This is the backside of the kidney where you can see that the buttress sutures have been placed, where the hole where the tumour has come out of has been successfully repaired. It's not leaking urine, it's not bleeding, and you can see that the kidney is a nice pink colour, which is exactly what we're after. And this really, the eyeball test of a kidney transplant is usually a very good indicator of a successful outcome. The biochemical success is that you can see the marker of kidney function we use is called creatinine. You can see that before the operation, her kidney function, her creatinine level was over 700 or 800, which is end-stage kidney failure. But just one day after the operation, this has fallen to 200, and this continues to fall. And she continues to this day with outstanding kidney function. And if she looks after this kidney, there's no reason why this will not last 40 years for her. So I think what we've done is illustrate what 3D imaging is capable of doing. And in this case, we've saved her father's life by removing a kidney with a tumour in it, and also given this young mother her life back off dialysis. And this should improve her quality of life and at least double her length of life, and hopefully will keep her alive for the next 40 years quite nicely. That's all I have to say. I think that's all the team have to say. So we'd be very, very pleased to take any questions or answers that any of you may have and that we can try and answer for you. And I'd just like to say thank you very much for your attention, and thanks for your interest in listening and logging in today. Thanks very much.
Fantastic stuff. That's the third time I've heard this, and I'm still impressed. It's a fantastic use case and fantastic use of technology. And in fact, we even got an ovation in South by Southwest when the lovely image of the blood flowing back into the kidney was presented. We've got a few questions here, so thank you for those. I'm going to kick off one, which asks the question, so do you just print for purposes of transplant planning?
Yeah, so I think I'll take that one. So no, Nigel, we actually do it for every specialism in medicine. So when we approach hospitals, generally what we would say is we can take any two-dimensional imaging data set, whether it be CT, MRI, PET or SPECT, and we can reconstruct those into one three-dimensional image for the surgeon to use. But what we have seen over the past 3 or 4 years is a trend in a number of different specialties actually approaching us. So the main specialisms will be cardiology, so using it for things like planning TAVI or TAVRs or assessing congenital deformities. Orthopedics, where surgeons would approach us with complex traumas or pediatric pathologies. and oncology. So, like Tim said, looking at tumours within complex structures and trying to analyse the tumour size and location in relation to other structures like vasculature and different portions of anatomy around it. So the kind of remit's quite wide, but the main specialisms that we would look at the moment are orthopedics, cardiology, and actually one of the emerging technologies that we're seeing on a more regular basis is in neurosurgery, where we would assess aneurysms and skull-based tumours for a number of different hospitals.
Fantastic. Another question here: do you just work in the UK, or are you worldwide?
Yeah, well, we do work in the UK. We are on the framework for both the NHS and the HSE, but we've also have a great opportunity to work with a lot of the US hospitals. And like Dan was saying, we've been working quite closely in a number of hospitals in the neuro department.
Yeah, and I think to expand on that, we see a lot of applications being shown in the NHS and HSE, but one of the kind of faster growing markets for us as a company is in the US, and in particular with larger hospital sites when they're actually trying to bring 3D printing in house, and it's quite a complex thing to actually implement, where traditionally you would need radiologists and printing engineers and biomedical engineers, but using Axial 3D's technology and along with the new sort of more modern 3D printers that are a little bit more user friendly, it's becoming more and more accessible to more and more hospitals.
Yeah, and also by then using our own ordering platform, we've a turnaround time of about 48 hours. So by using that platform, we're still able to send those cases out to US hospitals in that turnaround time, along with using print labs in Europe and the US.
Okay, super. Thanks for that. Someone's asking, in their experience, radiologists need to be the one to segment the data set. They are the experts in the anatomy.
Yeah, so I'll take that one. So internally in the team, we have a number of biomedical engineers who are trained in traditional anatomy and medical physics. So the majority of the less complex 3D prints will be segmented by them. But with regards to anything to do with oncology or anything that's being utilized for training purposes for the machine learning algorithms, they will always get oversight by the biomedical engineers and verified by them. And then a second verification will be done by a team that we have here in Belfast of expert radiologists to make sure that the segmentation that has been done on the two-dimensional images by the biomedical engineers are anatomically correct and accurate.
Okay. There's a question here. Is this something you think will be used mainstream by transplant surgeons? And what do you think the impact is?
So,
in terms of a straightforward transplant, then I don't know that this would add anything to a straightforward transplant. But when we're looking at these complex transplants, and in particular, I've got an interest in auto transplantation, which is where we take kidneys from which are diseased, take them out, repair them on the backbench, and then put them back into the same patient. This is an area that I'm developing quite a bit of interest in, and the last few cases that we've had 3D models made for, it's been invaluable from a number of perspectives. The first is that we're able to plan the procedure much more easily, and surgeons, when they come to the end of their learning curve, we're very adept at creating 2D images and then creating a 3D structure in our own minds. But my interpretation of a 2D image is going to be very different to Dan, for example, his interpretation in his own head of a 2D image. And the 3D structure really really wipes out variation and variability between two surgeons, so we both know what we're actually talking about together. So in terms, to answer that question, in terms of routine transplantation, I think it's probably unnecessary, but when we're talking about complex transplantation with complex vasculature or perhaps disease within a kidney that needs auto-transplanted, then these are invaluable tools to learn. The second thing in terms of value of the 3D imaging, and I'm talking about this hot off the press, having used this as an example this morning with a patient, is that I was able to show them a 3D image this morning of a very complex tumour of the renal vein, which thankfully Axial 3D managed to rush to me yesterday at a very short notice, which I'm very grateful to them for. And the patient himself was blown away, because trying to explain a complex tumour in a complex area of the body on a 2D image to the patient was impossible. And when I produced this model, it made everything clear, and the conversation that I then had with him and his wife was revolutionised. We were able to point out structures in minute detail, and he was able to understand and take on very complex issues, and as a result, that then went forward to his decision making as to whether he would go for life-threatening complex surgery or not. So invaluable for patient education as well as preoperative planning. So thanks very much, guys, for this.
Yeah, and I think just to expand on that, everything that Tim was just saying is reflective of pretty much every healthcare provider that we are working with at the moment. I was just in Tallahassee Memorial Healthcare last week with a number of neuro and cardiac surgeons, and they see the exact same trends in improving diagnosis, improving the ability for them to explain that diagnosis to the layman, which is the patient, and actually get them to understand exactly what is happening.
I think that maybe I could come back to that as well. I think one of the key things is one thing you mentioned early on in the talk, that you wanted to make this as routine as X-rays. I think the fact, and it blew my mind away today, because I had this image, I had the 3D model before I saw the patient. Preoperative planning and making these images as routine as X-rays, I think this is the way that we in healthcare have got to go in terms of educating our patients and giving them autonomy over the decisions that they're going to make about their own operative experiences. Without these, trying to illustrate that it's all very well for surgeons who are at the top of their learning curve in terms of interpreting 2D data, but patients don't have the benefit of the years of training that we've had in terms of interpreting these images, and the 3D image is actually the key to what their decision making is and the autonomy that they will have over whether they go for these operations or not. So whenever you talk about revolutionizing healthcare and making these routine, I applaud that, and I want it to happen today in my practice, please. Thanks very much.
Okay. Here's a more technical question, perhaps. What would the file output be? A standard .stl or a more tailored .3mf?
So specifically around the developments of the algorithms. So the original images that we would ingest into the system are all standardized under a DICOM format, and then these are then processed into one of two different standard file formats, at .obj or .stl. However, we have a number of different API links at the moment with different 3D print providers, and internally in Axial 3D we have access to every different printing modality, so we know how those files should be prepared. And what we can also do on top of that is, if the surgeon or the radiologist within a hospital requires it, we can take the output from the algorithm and then run that through a standard process to actually give a file format specific for a 3D printer within a hospital. So it means that any surgeon anywhere in the world can just put a single file into the printer without needing to learn how to do the engineering principles behind 3D printing.
Fantastic. A question about the presentation, and maybe a more technical question as well. So how was a kidney printed in clear resin, but also in multicolored material?
Yeah. So the kidney was actually printed on an SLA printer, which meant that before the print file was created, we had to go through a number of steps in order to make contrasting channels so that we could inject the color into the model in the post-processing steps. So once it's been segmented and the OBJ files created, we would take the individual objects and hollow those, and then produce a file that we can put into the printer that we will know will print. And then in the post-processing steps, like I said, Tim had highlighted what colours they wanted each of the parts coloured in. We injected those with those individual colours, which then allowed us to produce the clear and contrasted model.
Okay, great. So what is the automatic segmentation ratio that you have? How many are automated? And how many have to be manually segmented?
So I think I'll take that one. So internally within the company, the machine learning algorithms that we have currently developed, the foundation is mainly built on an orthopedic algorithm. So the majority of the cases that we get, around 50 or 60%, are within orthopedic specialisms. So all of those cases that are currently coming through Axial 3D do go through those processes. The two other main specialisms that we're developing out automatic algorithms on right now are specifically within neurology and cardiology, with the view that in around 6 or 12 months to get the same processes in place that we have for orthopedics and build on that foundation that we have to make a completely automated algorithm for those specialisms as well. Because I think to follow up on what Tim was saying, the only way to make this whole process routine is to completely automate those processes out, the process of segmentation. So for us as a company, the main trend has been specifically within orthopedics, cardiology, and neurology, but with the view that we want to expand into every specialism within medicine.
Okay. We've got the last question, I'm afraid. Does this slow the process of patient transplant at all? What happens in the case of an emergency? Is there any time to make rush decisions?
Yeah, that's an excellent question. Thanks very much for asking. I'll just point out that there are two types of transplant. There's living donor transplant and deceased donor transplant, and we would technically call the deceased donor transplant the emergency transplants because they happen at short notice. In terms of living donor transplantation, we often have quite a good lead time into preparation for the transplant, where we can review the images, review the tissue types, review the different processes, and in some cases, if the donor is not suitable, then we can try and find another donor, which obviously in our case wasn't available. In terms of the living donor, for example, in this case, it slowed down the process by a matter of minutes because basically we could take the tumour out on the backbench and repair it very quickly. While Pauline was coming down to theatre, the tumour was in the histopathology lab being analysed, so it didn't really slow things down very much at all. In terms of emergency work, because we don't have imaging of the organs prior to a deceased donor passing away, then there's no images that we can provide to a 3D printing company in the main that would be able to provide us with images. Although it would be very helpful, it's probably unethical to put donors through investigations that don't really benefit them. So when the first time that I will get to see problems is when I have the kidney in my hand, and there's not really any way around that, I think, from an ethical standpoint. I hope that answers your question.
Okay, and I think just to wrap up there, one of the things that we would love to do for any clinicians on the call, as a thank you for joining us today, is to offer up a free sample of a medical 3D print for any complex cases that you're currently working on right now. So if you just go on to axial3d.com/try and submit your details there, we'd love to help you out with your next complex case. And I think if there's any more questions from the audience, feel free to follow up with the team directly, and we'd love to hear from you.
Okay, fantastic. So thank you very much to the team in the room. Fascinating discussion as ever. Hope you all got something out of it, and thank you wherever you're listening and getting involved. And as Dan says, please do follow up on the website, and we'll be in touch with you for your further questions we didn't have time for. Thank you very much, and goodbye.